All right, so this is Chapter 34, Nursing Care of Patients with Lower GI Disorders. This is chapters 45 through 48 in your ATI, but in your MedSurg text, this starts on page 743. We're going to quickly review anatomy and physiology of the lower GI tract and then discuss disorders such as constipation, diarrhea. We'll talk about inflammatory and infectious disorders. We'll also discuss hernias, GI bleeds, absorption disorders, obstructions, and then we'll talk about cancer. And then we'll talk about ostomies as well. And as always, we'll discuss nursing care and interventions for patients with disorders of the lower GI tract. So the lower GI tract includes the large and small intestines, along with the rectum and anus. The small intestines, as a review, is where digestion is completed and nutrients are absorbed, and then the large intestine is responsible for indigestible material. The mucosa also absorbs significant amounts of water, vitamins and minerals.
And then the rectum and anus are the end of the lower GI tract where feces is eliminated from the body. So constipation happens when feces is held in the rectum longer than usual for a person. When this happens, more of the water is absorbed and the feces becomes dry and hard to pass. There are many causes for constipation, such as medications, different disease processes, etc. Prolonged constipation is called obstitation or obstipation. Some prevention strategies include a high fiber diet, and then increasing fluid intake, and then exercise as well. Signs and symptoms of constipation can be abdominal pain, abdominal distension, indigestion, rectal pressure, incomplete emptying of the bowel. People can have headache or fatigue or decreased appetite as well. Some of the complications of constipation are fecal impaction, when the fecal mass is so dry that it can't pass. Ulcers may also develop from the pressure a mass or the mass of stool puts on the mucosa. Straining, which can cause the Valsalva maneuver, can lead to cardiac or neurological or respiratory problems. If the patient has a cardiac history or a history of hypertension or a recent MI or myocardial infarction or heart attack, straining may cause cardiac rupture and death. Megacolon can also occur and obstruct the colon. And chronic laxative abuse can lead to colonic mucosal atrophy or muscle thickening and fibrosis. How the constipation is treated depends on the cause. Some of the interventions involve a high fiber diet. Apparently I can't say fiber today. Again, increasing fluid intakes like to 2 to 3 liters a day. Working on exercises to strengthen abdominal muscles. Using bulk forming agents or stool softeners. These should be used instead of laxatives to help with bowel movements. We want to provide education such as setting a daily defecation time or doing bowel training. Definitely appropriately responding to the urge to defecate and not holding it. Because as discussed before, when people repeatedly ignore the urge to have a bowel movement, this causes the musculature and the rectal mucosa to become insensitive to the presence of the feces, and so then they don't really react appropriately when they need to have a bowel movement. Then for those patients on palliative care and receiving narcotic, remembering that medication Relistor may be given to help treat with narcotic-induced types of constipation. So for data collection, talking about bowel movements can certainly be fairly embarrassing for some people, so establishing a really good report is important. You want to make sure to provide for privacy as well. You want to know how long they've been constipated, any contributing factors like diet or exercise or fluid intake. What is their normal pattern of having bowel movements? Do they have any medical history? Do they use laxatives? When was their last bowel movement, and the characteristics of that stool? You want to look at the abdomen and listen to the bowel sounds, and then palpate for any masses or tenderness. Then you want to inspect the perianal area for any fissures or hemorrhoids or any type of irritation as well. Nursing diagnosis include constipation related to irregular defecation habits, certainly anxiety related to pain or stool incontinence, deficient knowledge related to practices to prevent or strategies to prevent constipation. So diarrhea, this is when fecal matter passes through the intestines too rapidly, and this leads to decreased absorption of water, electrolytes, and nutrients. Diarrhea can be caused by bacteria or viruses or other types of infections, certainly food allergies or intolerances. Medications can cause diarrhea. I mean, every single one of the ones that we look at have nausea, vomiting, diarrhea. Or it can be caused by an inflammatory process. Certainly prevention strategies should include good hand hygiene to prevent any type of infections and proper food handling practices. Also not diluting formulas used for enteral feeding, which reduces the risk for contamination of those formulas. Signs and symptoms include a possible fever if the cause is an infection, foul-smelling stool that may contain undigested food particles, mucus, blood, or pus. Diarrhea may have an explosive type of onset, which can be really very embarrassing for the patient. The patient may also have nausea or vomiting or abdominal cramping, or they may also have distension as well. They may also experience anorexia or intestinal rumbling. The fluid loss can also lead to weakness and dehydration. So for these folks, thirst is fairly common. So people that have diarrhea or chronic diarrhea tend to be very thirsty. Really identifying the cause is important and may be accomplished through stool studies, but the first priority is to replace fluids and electrolytes. An elimination diet may be used to try to isolate foods that may be causing the problem. The patients are also instructed to increase bulk in their diet. They may also use antidiarrheals like Lomotil or Imodium. If antibiotics are the cause, then causing that disruption in the balance within the mucosa, then probiotics can be used to restore normal flora in the gut, and that could help. If the patient has an infection, then they'll be started on some type of antimicrobial depending on what the causative agent is. Nursing diagnosis include acute pain related to abdominal cramping, distension, and diarrhea related to possible infection or possible irritating foods. There's definitely a risk for fluid volume deficit depending on the frequency of when the stool is passed, and insufficient fluid intake. There's a risk for infection related to imbalance in intestinal flora or improper food handling, and then definitely a risk for impaired skin integrity related to the frequent stool passage, and then also dehydration as well. So appendicitis is an inflammation of the appendix, and because it's of its really small size, it's susceptible to infection. Signs and symptoms include fever, nausea, vomiting, anorexia, right lower quadrant abdominal pain. They'll also have an increased white blood cell count related to the infectious process. They should have normal, or they will have normal bowel sounds. They usually have a rebound tenderness, so this means like if you were to push on the space that where the pain is, it may elicit some pain, but when you release the pressure, it causes an extraordinary amount of pain. So that's called rebound tenderness. Appendicitis is usually diagnosed through an ultrasound or a CT. The patient is kept NPO. That way, in case they need to go to surgery to have their appendix removed. After surgery, the patient may have an NG tube, although I haven't seen this really commonly, but they may have it. We'll also need to monitor for signs and symptoms of peritonitis. Certainly, we're going to do some pain control. With all surgeries, we want to promote walking early, coughing and deep breathing also to prevent complications, and then we're going to teach them about splinting when they do their coughing so that they don't create problems there. Peritonitis, so we've talked about this a couple of times, but this is an inflammation or infection of the peritoneal cavity. Peritonitis, I can't even talk today. Peritonitis is very serious condition that can be life-threatening, and there are many causes. Throughout this lecture, you're going to hear it as a possible complication to a lot of different things. Signs and symptoms include abdominal pain, abdominal rigidity, nausea, vomiting, and fever. Usually they have a lot of pain. Diagnosis is done by an abdominal x-ray or a CT to see if there is any distension or to see if they can see the perforation. White blood cell count will be elevated. A paracentesis and laboratory studies of the fluids is done to identify the causative organisms. And then exploratory surgery may be done to identify the cause as well as repair it. The patient is kept NPO because of the impaired peristalsis. An NG tube is placed to decompress the stomach. Fluid and electrolyte replacement is really important, not only to treat the hypovolemia, but to prevent shock as well. Antibiotics are given to treat the infection. Again, surgery may be done to repair the perforation or excise or drain a tumor or abscess that may be causing the problem. Also, the patient may get an ostomy placed to divert feces and allow a resolution of the infection or the problem. Pain control is very important to recovery. We've talked about this before as well. And then depending on the severity of the problem, some patients may require TPN to meet their nutritional needs. Complications include intestinal obstruction, hypovolemia caused by fluid shifts into the abdomen, and sepsis from the bacteria entering the bloodstream. Septicemia may lead to septic shock and death. There's also a risk for wound dehiscence and evisceration that actually is a risk for all patients when they've had abdominal surgeries. Nursing diagnosis include acute pain, deficient fluid volume, and then imbalanced nutrition less than body requirements. So diverticulosis and diverticulitis. So a diverticulum is this outpouch of the bowel mucosis membrane. It's caused by a pressure within the colon and weakness of the bowel wall. And then diverticulosis is when there are multiple diverticuli, but there is no evidence of any type of inflammation or infection. And then with diverticulitis, this is when inflammation and infection develop within the diverticula when food or bacteria get trapped within these little outpouches. Again, diverticulosis is caused by an increased pressure in the bowel and weakening of the wall, which, as discussed earlier, are some of the complications with chronic constipation. A major cause of this disease is decrease or lack of intake of dietary fiber. This most commonly affects people over 60, which makes sense when you think about the effects of aging on the GI system and how they have slower gastric motility, which can lead to problems with constipation. Diverticulosis is usually asymptomatic, but for diverticulitis, signs and symptoms include change in bowel patterns, cramping in the left lower quadrant of the abdomen. Bleeding may occur along with fever or fatigue, anemia or weakness. Can also cause abscesses to develop that may lead to peritonitis if the abscess were to rupture. Some of the therapeutic interventions, well, first let's talk a little bit about diagnosis. This is usually confirmed with some type of scope, so a sigmoidoscopy or a colonoscopy. It could also be diagnosed with a barium enema, or a CT scan may also be done. If stool specimens are collected, which usually when there's any type of bowel problem they may show some occult blood. A complete blood count may also be done to monitor H&H, and also to monitor for signs and symptoms of infection with the white blood cell count. Abdominal x-rays may be done also to identify perforations. So therapeutic interventions, since pressure or constipation may be one of the causes, we want to prevent constipation. If the patient is hospitalized, they may need to be hospitalized, and they may get intravenous antibiotics and pain control. If it's severe enough, the patient may need a temporary colostomy to allow the inflammation to subside. We want to teach the patient to increase fiber, prunes, raisins, peas, those kind of things. Fiber should be increased slowly to prevent problems with gas or discomfort. They also need to avoid foods that have nuts or small seeds like tomatoes or raspberries or blackberries, because these can become more easily caught in the diverticula, and then remembering that when food or other things get caught in the diverticula, this can cause the diverticulitis. Nursing diagnoses include acute pain related to the inflammatory process and risk for deficient fluid volume related to diarrhea or fluid shifting from the circulation to the peritoneal cavity. Others might include acute pain or knowledge deficit as well. So with Crohn's disease, this is an inflammatory bowel disease. It can affect any part of the intestine, but it most commonly affects the terminal portion of the ileum, or the first part of the large intestine. The exact cause is unknown, but it tends to run within families. Other possibilities are autoimmune processes or infectious agents. There's a higher prevalence in women, and it's usually diagnosed between ages 15 and 30. Again, smokers have an increased risk for Crohn's disease. The patient will have periods of remission. Physical or psychological stress may trigger exacerbations. The inflamed areas from Crohn's disease can alternate with areas of healthy tissue, so the inflamed areas are referred to as skip lesions. Signs and symptoms include abdominal pain or cramping, which is unrelieved with defecation, weight loss. Here, because of a couple of issues. First, eating can cause cramping pains, so the person will avoid eating to avoid more pain, but also because there's poor absorption of nutrients related to the inflammation of the bowel, and then also because of the diarrhea. There can be chronic diarrhea as well, and this can cause, as talked about before, fluid and electrolyte types of imbalance. Patients may also experience arthritis or skin lesions, inflammatory disorders of the eyes, and abnormalities in liver function. There are many complications that can happen with Crohn's. As discussed, lack of eating to avoid pain, and also poor absorption lead to problems with malnutrition. The inflamed intestine may perforate, which can lead to formation of intra-abdominal or anal fissures, abscesses, or fistulas. Fissures are these unnormal tracts or ulcers. Fistulas are abnormal connections between structures. Here in this picture, you can see examples of several different fistulas. To look at this a little bit bigger, you can look at the picture in your book. It's on page 753. So for diagnosis, blood tests are done to look for anemia and infection. They'll also evaluate liver function, as remember we talked about there could be some abnormalities in liver function along with Crohn's disease, and also to look for problems with protein absorption. Stool as a test, tests will be done, and they'll be tested for infection or occult blood. Endoscopic exams will be done to biopsy multiple sections of the diseased bowel, and then they can use that also to diagnose Crohn's. Ultrasound can be used to identify fistulas or areas of bleeding, and then multi-phase CTs or MREs can provide more detailed images of the structures. So Crohn's is not a curable condition, so the goal of treatment is to achieve and maintain remission. The idea is to treat the inflammatory process in the bowel. Some of the medications used to treat these symptoms include anti-inflammatories, antibiotics or antidiarrheals. Biologics can be used, and these selectively target agents in the inflammatory process and then block their effects. You can also use corticosteroids or other immune suppressants to help with inflammation and to suppress the immune response, since it is thought that it may be an autoimmune disorder. So as complications develop, surgery may be needed to relieve obstructions or strictures or to repair fistulas or perforations that might happen. If nutrients are not being absorbed properly, the patient may require tube feedings or TPN. They may also need to take other supplements like B12 or calcium or vitamin D. We need to provide support and education. This is really important. The patient needs to know how to reduce the likelihood of an exacerbation. We can teach them about reducing stress and also avoiding foods that may cause problems. They also should be told that adequate fluid intake is really, really important and essential for preventing dehydration. So ulcerative colitis, this is a lot like Crohn's, except it occurs in the large intestine and rectum as opposed to anywhere in the GI tract. The lesions spread in a continuous fashion rather than intermittently throughout the large intestine and usually involve the rectum as well. Again, this differs from Crohn's, as Crohn's has those skip lesions and ulcerative exacerbation. The cause is not completely known, but there are a lot of theories, such as an infectious process or allergies or autoimmune
responses, maybe radiation or exposure to other environmental agents. Signs and symptoms include abdominal pain, diarrhea, rectal bleeding, and fecal urgency. Nausea, vomiting, anorexia, and weight loss are also very common. There's also potential for fluid and electrolyte imbalances and calcium loss. Anemia can result because of the rectal bleeding. Like Crohn's, there are also issues with malabsorption, so serum albumin may be low. Another similarity to Crohn's disease is that the patients can also develop problems with arthritis, skin lesions, inflammatory eye disorders, and abnormalities of liver function. So liver function should also be checked out. Complications can include the potential for hemorrhage, bowel obstructions, perforation, which then can lead to peritonitis. Certainly malnutrition can happen, but it's less common than with Crohn's. And then people with ulcerative colitis have an increased risk for colon cancer as well. So for therapeutic intervention, diet and lifestyle changes first, and then medications to treat the symptoms are used. So like Crohn's, medications like anti-inflammatories and antidiarrheals, immunosuppressants, and corticosteroids may be used. Surgery may be needed if symptoms are bleeding or severe, or if the patient develops a toxic megacolon or a perforated or perforation. So surgery that can be done to cure ulcerative colitis would be removal of the colon. Again, supplements may be needed to avoid or correct problems with malnutrition.
So assessment data and data collection for folks with inflammatory bowel disease should include information about their symptomology and also information on food sensitivities or allergies. We want to know about caffeine, alcohol, and tobacco intake. Assess their nutritional status and hydration status, if they've had any recent weight loss. We also want to look at the perianal skin to assess for irritation or excoriation. And because stress is a factor in exacerbations, we want to also check out their emotional status and their coping skills as well. Some of the nursing diagnoses include acute pain, diarrhea, deficient fluid volume, anxiety, impaired skin integrity, ineffective nutrition, less than body requirements, or ineffective coping. Certainly, there can be problems associated with body image as well, and especially if they've had surgery and an ostomy placement. So irritable bowel syndrome, or IBS, this is an altered intestinal mobility or motility where it's increased, and sensitivity to the visceral sensations. With this, the bowel mucosa are not changed or damaged. With IBS, there are times when the contractions are violent and last a long time, causing diarrhea, or there's no contraction at all, causing constipation. Because the contractions are disorderly, IBS can involve a combination of diarrhea and constipation, or just one or the other. Flare-ups can be caused by infection, other illnesses, or even the stress from a menstrual cycle. So psychological stress. It can also be caused by food intolerances. And all of these things can exacerbate symptoms. It's more common in women, and there is a tendency for IBS to run in families. Signs and symptoms include gas and bloating, constipation, diarrhea, abdominal pain, certainly depression and anxiety around all of the symptomology. Mucus may be seen in the stool, and this is not abnormal and does not usually cause any problems. Diagnosis is based on history and physical examination. They may also do stool evaluations, colonoscopy or sigmoidoscopy to rule out other disorders to make sure it's not Crohn's or ulcerative colitis or something else that is causing the problems. Lactose intolerance is also ruled out, and they have the patient avoid milk products for a period of time to see if this might be the problem. So symptoms can generally be controlled by diet and lifestyle changes, along with stress management and medications. We want them to be avoiding trigger foods such as fresh fruits and vegetables. Caffeine and alcohol can also cause problems, so we want them to avoid those to decrease symptoms. We want them to be on a high fiber and bran diet. We want them to eat smaller, frequent meals, and this will help reduce the contractions. Certainly, stress management or behavioral therapy to help with relaxation. Exercise helps in relaxing the bowel, but also is just good for overall health. Medications, they're used depending on the type of IBS and vary from using antidepressants or SSRIs or other types of medications or antispasmodics as well. So assessment should include signs and symptoms, intake and output, stress and coping abilities. Nursing diagnosis include constipation or diarrhea related to irregular GI tract motility, and also readiness for enhanced self-management related to the desire to manage their IBS symptoms. So abdominal hernias, this is a protrusion of an organ or structure through a weakness or tear in the abdominal wall. And this will happen with an increased intra-abdominal pressure. The weakness or tear, along with this increased abdominal pressure, like coughing or straining or heavy lifting, will cause the organ or structure to protrude out of the cavity that it normally is in. Contents of a hernia can be intestine or the omentum. Hernias can be direct or indirect. Indirect hernias are caused by a defect in the structural closure, while direct hernias are acquired and arise from a weakness in the abdominal wall, usually at an old incisional site. Inguinal hernias are in the groin. For men, this is where the spermatic cord emerges, or for women, where the round ligament emerges from the abdominal cavity. This is a good example of an indirect type of hernia. It is most common in men. Umbilical hernias are around the umbilicus and are caused by a failure of the umbilical orifice to close. Umbilical hernias are seen most often in obese women and then also in children. And then lastly, a ventral or incisional hernia. These are caused from a weakness in the abdominal wall following abdominal surgery. So this is an example of a direct hernia. This type of hernia happens more often if the patient is obese or had poor wound healing, or a drain placed during surgery, or the patient received inadequate nutrition. Unless complications occur, there are usually little to no symptoms. The patient may experiencing this bulging at the site. If the hernia disappears when lying down or can be manually placed back in the abdominal cavity easily, it's a reducible hernia. When adhesions or edema occur and the hernia then may become, irreducible or incarcerated. If the blood supply and intestinal flow are completely cut off, then it's called strangulation. Incarcerated hernias can also lead to obstructions or gangrene or perforations, and symptoms include pain at the site and nausea or vomiting. Diagnosis is made by physical examination. If the hernia is reducible, no intervention is usually needed. Support devices like supportive binders or briefs can apply pressure to keep the hernia in place. If the hernia is strangulated or bowel obstruction is present, then they may need to have, or usually will have, an emergency surgery for treatment. Surgeries, the herniorrhaphy is an incision that is made and the content is then placed back into the abdominal cavity, and then the incision is closed. And the hernioplasty involves putting the hernia back into the abdomen and then reinforcing the mucosal wall with a wire or a fascia or a mesh. Sometimes bowel resection or temporary colostomy might be necessary if the hernia is strangulated. So for nursing care, patients should be taught to avoid heavy lifting or other activities that can increase intra-abdominal pressure. Maintaining normal weight, not smoking, and eating high-fiber foods is also recommended. Patients also should be taught signs and symptoms of incarceration or strangulation, and to notify the doctor immediately if any of these occur. If the patient is using a supportive brief, they should also be taught to do skin checks to make sure that the pressure that is exuded on the skin from these garments don't cause any problems with their skin integrity. If the patient has surgery, post-operative care again includes deep breathing, but again we don't want coughing because that increases the intra-abdominal pressure. If they do have to cough or sneeze, we want to teach them about splinting techniques. Ice packs and elevation can be used to reduce scrotal swelling in men. Patients are also taught about wound care, signs and symptoms of infection, and to avoid lifting, driving, and sexual activity for 2 to 6 weeks following the surgery. Malabsorption can be caused by dysfunction of the small intestines or inflammatory disorders like Crohn's or ulcerative colitis. The primary malabsorption disorders are celiac disease, which is a sensitivity to gluten, which is thought to cause malabsorption of protein. Gluten is a protein that is found in wheat, barley, and rye. The other primary malabsorption disorder is lactose intolerance, and this is when there is a deficiency in lactase, so milk sugars are not broken down. The high concentration causes an osmotic retention of water in the colon, which in turn causes watery stools or diarrhea. Diagnostic testing for malabsorption disorders include monitoring the H&H and also mean corpuscular volume, which is used to monitor malabsorption of vitamin B12. Upper GI series may be done, biopsies of bowel mucosa, and also stool studies. Table 34-7 on the bottom of 761 has a lot more information on diagnostic testing that you can look up for malabsorption disorders. So general signs and symptoms include weight loss, weakness, and general malaise for malnutrition. Lactose intolerances can cause abdominal cramping, excessive gas, and loose stools after consuming milk products. And then celiac disease can cause a multitude of symptoms in various body systems. Your book has a website that's listed. It's www.csaceliac.org, and you can check it out if you want to get more in-depth information in regards to celiac disease. Other complications include vitamin K deficiencies, which can lead to increased bleeding risks. This is why we're monitoring H&H. Problems with calcium deficiencies, folic acid, iron, and vitamin D or B12 deficiencies as well. For therapeutic interventions for celiac disease, patients are started on a high-calorie, high-protein, gluten-free diet. Many products contain gluten, so the patient needs to be instructed to read labels very carefully. For lactose intolerances, patients can avoid milk products, or they can use Lactaid, which is an over-the-counter lactase substitute. This will help digest about 70% of lactose in foods, which makes them a lot more tolerable. Nursing care includes monitoring fluid and electrolyte status and also nutritional status. Education on dietary restrictions and supplements may be needed as well. For patients with problems with diarrhea, keeping perianal skin clean and dry is important, and barrier ointments may also be used to help to protect the skin. Bowel obstructions occur when content is blocked. This can happen for a variety of reasons, including adhesions or twisting of the bowel or strangulation hernias or a volvus, or they can be non-mechanical, which involves impairment of peristalsis that happens after abdominal surgeries, trauma, or from ischemia or infection. Obstructions can happen in the small or large intestine, and they can either be partial or complete. Signs and symptoms include abdominal pain, blood and mucus from the rectum, feces and phletus cease, or they stop passing stool and they stop passing gas. Fecal vomiting may also occur. Bowel sounds are high-pitched and tinkling, or they could be absent as things progress. And then there could be abdominal distension, and then fluid and electrolyte imbalances as well. X-ray or CT scan may be done to evaluate bowel loops for dilation, complete blood counts to evaluate hydration status, remembering that the H&H would be increased during dehydration because of the hemoglobin concentration. And then electrolytes are checked as well, as these can be depleted along with the dehydration. The patient is kept MPO if impaction is present. Interventions such as trying to do enemas or digital disimpaction may work to correct the problem. The patient may have an NG tube placed to decompress the stomach and to rest the bowel. Fluids and electrolytes are also replaced if needed. And then surgery may be needed to correct the problem. Parts of the colon may be resected. Sometimes temporary colostomy is placed, so again, the bowel can rest and heal. Nursing diagnosis include acute pain related to abdominal distension, risk for deficient fluid volume related to vomiting or deficient related to vomiting. Also, deficient knowledge or knowledge deficit can happen in regards to the condition, how to prevent constipation, etc. Assessment should include listening to the bowel sounds, palpating for distension or tenderness, assessing pain and vital signs, daily weights, again, looking at fluid volume status, and eyes and nose. If an NG tube is placed, then the gastric content that is coming out of the NG tube should also be assessed. So anorectal problems. The anorectal problems that were talked about in the book are hemorrhoids, which are enlarged veins within the anal tissue. They can be internal or above the internal sphincter, or external, which is below the sphincter. Most are caused by straining with bowel movements. They are also common in pregnancy. They can be caused by prolonged sitting or standing. Obesity and chronic constipation can also lead to hemorrhoids. The inflammation and edema that occur with thrombosis can cause pain. Bleeding can also occur. Treatment includes avoiding constipation and straining with BMs, avoiding prolonged sitting or standing, certainly increasing fluid and fiber intake to prevent constipation. Hemorrhoids can also be surgically removed or by rubber band ligation, where a rubber band is placed around the hemorrhoid, which cuts off the blood supply, and then that causes the tissue to die, and then it just sloughs off. There are also topical medications that can be used as well. After surgery, ice packs and sitz baths can help with comfort. Stool softeners are also given, and analgesics as well, because bowel movements after surgery can be really, really painful. Anal fissures, again, are cracks or ulcers. They are associated with Crohn's disease, as discussed earlier, but are also commonly associated with constipation. They can cause bleeding and severe pain, which may cause the patient to delay going to the bathroom and further exacerbate the problem with constipation, and then making symptoms even worse. Fissures are treated by softening the stool and preventing constipation so that they can heal. Sitz baths may also be used as they promote circulation. And then pain medications such as analgesics or suppositories may be used. Surgery can be done to remove the fissures if other measures are not working. And then anorectal abscesses. This is an abscess or collection of pus in the rectal area, and they are usually caused by E. coli, Proteus, Staphylococci, or strep. Like with other abscesses, signs and symptoms include redness, swelling, pain, fever, and sometimes drainage. They are treated with antibiotics or can also be surgically incised and drained, or INDs. After surgery, the area may be left open with packing so that it can be allowed to drain more effectively. So nursing care, postoperatively, pain control, sitz baths to not only keep the area clean, but also, again, to promote circulation and healing, dressing changes, stool softeners to prevent pain and straining with bowel movements. We also want to instruct the patient about the importance of keeping the area clean and dry. So for lower GI bleeding, the major causes are diverticulitis, polyps, anal fissures, hemorrhoids, inflammatory bowel diseases, and also cancer. Signs and symptoms include occult blood or membrane blood that is not visible, or melena, which is a black tarry stool that is caused by blood being in the GI tract more than 8 hours and being exposed to hydrochloric acid, or blood may be bright red. Like with any blood loss, if it's significant enough, it can cause signs and symptoms of hypovolemia, like hypotension, tachycardia, lightheadedness, and diaphoresis. And then treatment involves treating or correcting the underlying cause. Some diagnostic testing that may be done are checking stool for blood. H&H should also be monitored. And then if signs and symptoms of hypovolemia occur, they should be reported to the doctor immediately. A BUN may be elevated as a result of breakdown of proteins in the blood by the GI tract. They may also do digital rectal exam, colonoscopy, or sigmoidoscopy as well. We're going to certainly monitor the patient's stools and check for bleeding. We're going to monitor vital signs, and then we also will prepare them with diagnostic prep, and then nursing care for any of underlying disorders that are identified. So for colorectal cancer, as discussed before, colorectal cancer is one of the most common types of cancer in the United States. There are many risk factors, including family history, disease processes. Remember we talked earlier about ulcerative colitis is an increased factor for colorectal cancer. This type of cancer has also been linked to previous gallbladder removal and dietary carcinogens. The lack of dietary fiber slows passage of feces, which allows prolonged exposure to possible carcinogens. Excessive fat in the diet is also believed to be altered or to alter bacterial flora, which converts steroids into compounds having carcinogenic properties. Other risk factors include obesity, smoking, alcohol use, and then large amounts of red meat in the diet. Signs and symptoms include changes in the bowel habits, blood or mucus in the stool, abdominal or rectal pain, weight loss, anemia, obstruction. Oh, look, I listed anemia twice. Sorry about that, guys. And obstruction twice. Nice. I'll fix that later. Sorry about that. Complications include bleeding or obstruction, perforation, which again can lead to peritonitis. There can also be extension of the tumor to adjacent organs, and it can also metastasize to the lymph system and liver. So screening for occult blood in the stool can be done even from home, and then if blood is detected, follow-up with doctor should be done as soon as possible. Other tests include a colonoscopy, sigmoidoscopy, or proctoid sigmoidoscopy with biopsies. CT scans can be done as well, abdominal and rectal examinations. Immunological tests, which look for small amounts of blood. And then CEA, or that carcinoembryonic antigen, is a blood test that is done, and this can be present when epithelial cells divide really rapidly, and what happens is this provides an early warning that the cancer may be returning or has returned. So therapeutic interventions, there are a variety of surgeries that can be done, and they depend on the location and the extent of the cancer. So they can have different types of resections done, colostomies, and then also with all cancers, radiation or chemotherapy. The monoclonal antibody therapy, these are antibodies that enhance the immune system function, and they interfere with the cancer growth. So the antibodies attach to the cancer cells, which flag them for the immune system so that they can be destroyed. Removal of portions of the bowel may decrease absorption of nutrients, so TPN may be necessary. Post-operatively, assessment includes, of course, monitoring vital signs and lung sounds. We need to encourage coughing and deep breathing along with early ambulation. If a drain is placed in a perineal wound, moderate amounts of light pink drainage are expected, but large amounts of bleeding or drainage from any surgical site should be reported immediately. And then if the patient has an ostomy, we also need to be monitoring the stoma as well. So nursing diagnosis include acute pain related to tissue compression from the tumor, certainly anxiety and fear related to serious life-threatening illness, and then imbalanced nutrition, less than body requirements, related to nausea, vomiting, anorexia, or malnutrition or malabsorption problems. Nursing care includes support and education around diagnosis and treatments and what to expect. And then post-operative care is much like with any other surgery, and we talked about post-operative care a little bit earlier. So just keep those things in mind about coughing, deep breathing, early ambulation, and then monitoring for those problems with bleeding. So ostomy management. Ostomy is a surgically created opening that diverts stool or urine to the outside of the body. The stoma is the portion of the bowel that is sutured onto the abdomen. Just as a review, ostomies can be incontinent, which is the type where the person would need to wear an appliance to collect the stool or urine, or they could be continent, in which there's an internal reservoir that is created, and then the patient is taught to empty that. Abdominal ostomies include ileostomies, colonostomies, and urostomies. So ileostomies, this is where the terminal ileum is to the abdominal wall after a total colectomy. And there are two different types of ileostomies that can be formed. So the conventional ileostomy is an incontinent ostomy, and it, as implied by its name, the continent ostomy or ileostomy, such as a cock pouch or Barrett's pouch, is an internal reservoir where content collects, and then the patient is instructed to empty the reservoir 3 or 4 times a day. With the conventional ileostomy, it's a small stoma to the right lower quadrant, and it has this continuous flow of liquid, effluent, or feces. And then with the continent ileostomy, again, there's that reservoir, and it'll have that nipple valve, and then the patient will access that reservoir and empty it themselves, and again, about 3 or 4 times a day. Ileoanal anastomosis is where the ileum is attached to, sorry about that, excuse me for the sneeze. Anastomosis, which is a connection, and this is where the ileum is connected to the anus. Usually this procedure is done in 2 steps. First, the connection or anastomosis is done when the diseased bowel is removed and a reservoir is created and connected to the anus, and at the same time a temporary ileostomy is created to allow the reservoir to heal. And then after the reservoir is healed, the ileostomy is reversed, and then the patient can have bowel movements through the anus. And then with the rectal anastomosis, this is where the ileum is connected to the rectum instead of the anus. So this is a visual of a J pouch or a reservoir created with a ileoanal anastomosis. So you can see that a pouch is created which can store the feces, and it can then be evacuated. There are several different types of stomas, which include abdominal perineal resection with end stoma. There are double barrel stomas. There are end stomas with Hartmann's pouch, or there are also loop stomas or transverse stomas. Colonostomies are named by the location, so they can be ascending, transverse, descending, or sigmoid. The type of effluent or feces is dependent on the location of the bowel used. The effluent becomes less liquid and more solid as the location of the ostomy becomes more distal to the colon. Again, the types are end stomas, which are the proximal bowel end is brought through the abdominal wall. And then with the loop stomas, a loop of bowel outside the abdomen is brought out, and then there's a bridge under it to hold the loop in place. Double-barreled stomas are usually temporary and allow the bowel to rest and heal after trauma or surgery. Here, both ends of the colon are outside the abdominal wall, and they form two different stomas. The proximal stoma is the functioning stoma, while the distal stoma is like a mucus fistula. So a wound ostomy incontinence nurse should be consulted before surgery. They can help to prepare the patient both emotionally and physically for the surgery. They also have expertise in stoma site selection and will consult with the surgeon to ensure that the placement of the stoma is located in the most functional place possible. Certainly the location of the stoma is very important, as a properly placed stoma can help to avoid discomfort or the inability of the patient to perform self-care. It can also avoid leaking or poorly fitting devices. Preoperatively, teaching should include information on coughing, deep breathing, certainly splinting, and of course early ambulation. Bowel prep will also be done to cleanse the bowel and to reduce the risk of infection. And oral or antibiotics, oral or IV antibiotics can be given as ordered. So nursing diagnosis can include deficient knowledge about appliances or how to change them, daily care, hygiene, certainly skin care and dietary considerations. Body image disturbances, sexual dysfunction, or ineffective therapeutic regimen management. Could also include a risk for injury to the peristomal skin, or there could be certainly problems with peristomal hernias, stomal prolapse or necrosis, and then ileostomy blockage as well. Postoperative care is much like after any other surgery, monitoring vital signs, encouraging coughing and deep breathing, and early ambulation. We also want to assess the stoma. Again, the stoma should be pink and red, pink to red, and it should be moist. A bluish color indicates that there's an inadequate blood flow to the stoma, and then if it's black, this indicates necrosis. So we want to look at the skin around the stoma and monitor it for irritation. Also, the stoma will shrink a little bit over the weeks. We want to look at ostomy care and appliance changes and do teaching with the patient about care, appliances, activities, and when to seek follow-up care. And then definitely give them some resources for support. So that's the end of this lecture. If you have any questions, again, you can post them on the discussion forum under questions. You can always email me or text me or call me. You can also make an appointment to see me to discuss any concepts that you don't understand or that you just need clarification on. Thanks, and I hope you guys have a great day.